All right, so this is an opportunity for the rest of the team to benefit from the conversations that Zach is having on Tuesday as he does his rounds as the chief clinical officer. So this week's topic is focused on conservative rotator cuff management, and it is in a direct access situation. The topic that we will touch on first will just be day one focuses with regards to screening and assessment, and then areas of focus for that first session. So Zach, I'll let you kick things off.
Yeah, so I think big considerations with the direct access patient, especially when you're talking about suspicions of a rotator cuff tear, is do we need to get another set of eyes on this thing? And when I'm going through subjective and we're going through our initial screening, three big things that I want to keep in mind are, do they have pain that is either non-predictable or uncontrollable? So if they have persistent, significant pain, that could be an indicator to get another set of eyes on this. If they're reporting instability, either with the mechanism of injury or since the onset of pain, they've had recurrent instability. And then a third one for me, if they can't get their hand above their head, if they have a rotator cuff pathology, it's pretty indicative that either they're just in a highly irritable acute phase or there's some structural integrity that's been lost, and it's probably not a minor tear, but a more major tear. So those are the three big ones. If any of those are present, I'm immediately thinking, hey, we can get done what we need to today, but I'm making the recommendation at some point in this session for them to follow up with the physician, get another set of eyes on this, see if either medication and or imaging is warranted, or just a second person speaking in regards to what diagnostics and prognostics look like.
Is it fair to assume that a lot of these situations would probably be following up after some kind of trauma or some kind of specific event? I imagine we're not always thinking about the direction of the insidious onset injury where we're going to be referring people out.
Absolutely. So I'm thinking these are people that maybe they had some sort of impact. So maybe they're an athlete, they play a contact sport, they were tackled or they were hit during the competition. Maybe they fell on an outstretched arm. It could be a throwing athlete that maybe they felt it during a throw or recently have felt it more consistently with throwing. Or it could just be somebody, general population, doing stuff around the house, moving, manipulating an object. I had somebody moving a piece of furniture the other day and was just holding it in an awkward position, stabilizing it overhead, felt something click, felt something pop in the shoulder, and that was what led them in.
And then after you've gone through some of your screening assessment, you feel like you are the right person to help this person. They don't need an immediate referral out, or even if you're going to potentially refer them out, just to kind of get a second set of eyes. What are some things you're focusing on in the first session?
First session, I think of three buckets. Something from pain management or symptom relief, and that may just be education on how do we modify provocative activities or just tell them which ones they shouldn't be doing at this time. Or is there anything they can do from either getting more education on medication, icing, heating, self-MFR, things that they can do just to manage pain. Then the other two big ones are how do we get this moving from a mobility standpoint and how do we get this moving from a strength standpoint. So I want them leaving day one with education on what they can do to make it feel better, but then how can we get this arm moving? And a lot of that's going to be dictated on what do they look like coming in. So for some people, it may be strictly passive means in which they're getting it to move. For others, they may be doing things more active assistive or active. So they should be leaving with at least 2 to 3 things from a mobility standpoint to get it moving within comfortable but progressively increasing ranges of motion. And then something from a strength standpoint, and I would say usually your best entry points here are going to be something from an isometric standpoint, or maybe we're introducing something from a closed chain standpoint where they struggle to do a lot of open chain moving the arm through space, but if we can get them in contact and in a weight-bearing position, they can get some more proximal stability, some more proximal recruitment, and just changing that environment makes it more comfortable for them. But pain management, range of motion or mobility, something strength-oriented, which is probably going to be either isometrics or some sort of weight-bearing closed chain type activity.